Rheumatoid arthritis is the most common autoimmune condition. It affects 1% of the population. Autoimmunity is when the immune system gets confused and starts attacking self. This can localise in lots of different tissues and organs, but in the case of rheumatoid arthritis, it affects the joints. This causes joint inflammation, swelling, and cartilage and bone erosion, causing very high rates of pain and disability. Osteoarthritis affects mostly older people, but rheumatoid arthritis affects people in the prime of their working life, so it causes a huge economic burden. There's also no treatment there's no cure for rheumatoid arthritis. The only treatment is lifelong immunosuppression, which leaves patients at risk of developing certain infections, cancers, cardiovascular disease, and stroke. Immunotherapy was first used as a cancer treatment. Immunotherapy is also known as a cellular vaccine. In the case of cancer, cells are isolated from a patient's blood, reprogrammed to be anti-inflammatory against the cancer or tumour, and injected back into the patient. This is to try and stimulate the immune response against the cancer to allow the patient to eliminate the cancer with their own immune system. In the case of autoimmunity, it's the opposite. So we isolate cells from a patient's blood, reprogram them to be anti-inflammatory, inject them back into patients, and this is to try and dampen down the aberrant immune response and allow targeted immunosuppression. So there's been 2 clinical trials for rheumatoid arthritis for this treatment, one in Australia and one in Newcastle. There's another one scheduled and currently recruiting in Newcastle, but there remains unanswered questions. The main one being the best injection route for this treatment, which is what my PhD is trying to answer. Depending on where we inject these cells, they will end up in different places and they will have a different therapeutic effect. And we want to choose the best injection route to maximise the therapeutic potential of this treatment. I'll be doing these studies in mice because it's not possible to do in humans. So we're going to fluorescently track and label the cells and then inject them, try different injection routes and see where the cells end up, what tissues and organs and what cells they interact with. That hopefully the outcome of my PhD will be able to find the best injection route. This will help optimise the next clinical trial, and if there's good results from that clinical trial, this could potentially end up in rheumatoid arthritis patients. It's a better treatment than what we have already because it allows targeted immunosuppression, so less adverse effects than the current treatments. So hopefully this will be a new treatment for rheumatoid arthritis.